But I'm really going to focus the majority of this talk on findings from the British Association of Dermatologists, Biologics and Immunomodulators Register, or BADBIR. I'm sure you've all heard about this registry before. This is a dedicated registry for safety set up for patients with psoriasis on systemic treatments, including new treatments and biologic treatments. But I'll really briefly touch on some new treatments that are out there as well to start with. So this is my conflicts of interest slide. Just to note that the BADBIR, the project is funded by the British Association of Dermatologists, but receives funding from numerous different companies as well. So I'm just going to, before I go and talk about our findings in BADBIR, just really briefly touch on 3 new treatments. Some of them are already in use out in the clinic, and some are imminently coming to the clinic to be aware of. So the first one is a new oral tablet called deucravacitinib, or SOTIC2, and this is because, cleverly named, because it inhibits a receptor called TYK2, and basically it's a new oral treatment. These graphs might mean not so much to you, but if we just break it down, the main outcome in psoriasis we look for is a 75% improvement in the PASI, or the Psoriasis Area and Severity Index. And here we're comparing the deucravacitinib with another oral tablet, which is relatively new, called apremilast. And you have a couple of lines there. I don't really have a pointer, but you've got a blue line, which represents the new drug, and the orange line, which represents the old drug, or apremilast. And you can see that for this PASI 75 marker, and also a static physician global assessment score, which is really talking about the percentage of patients getting no psoriasis or very mild psoriasis, you can see that it's quite a promising treatment. And as I gather, I think it's near the end for the NICE process, so you could keep your eyes out for this particular option soon. And really, this is a very busy slide. I don't really expect you to look at this, but I'm just putting this slide to kind of point out some quirks of this particular drug. So the only figure you need to look at is this number, the per 100 person years, and just to look at the bottom here. So basically, this one. And really, it's showing that it's a little bit of a quirk that this particular drug can give you acne, so that's a lot more than the comparator apremilast, and also folliculitis. But in terms of serious infection, it's got a lower rate, so it's relatively safe. So we're looking forward to having this option for, especially for patients who don't like the sound of having repeated injections. So this is just to talk about this drug is going through the NICE process anytime soon now. And the draft guidance is probably going to recommend this to be an option to be used in patients with moderate to severe psoriasis, much like the other types of biologics and other treatments we've got. Super quickly, Spesolimab, I have trouble pronouncing this one actually. This is a new drug under development for generalized pustular psoriasis, and it's quite promising. So there's 2 trials out there, one of which has read out after 1 single dose of this treatment, and you can see that it really does have a good effect. This bar or column or bar chart really shows the percentage of patients with no pustules, which is what you get with this particular condition. And you can see that compared to placebo, it does have a big effect. But just to note also that some people do get severe drug reactions from this particular drug at the bottom. So something called DRESS syndrome at 12 weeks. There are more patients with that. So it's something to look out for, but it's really good that we have some new developments and new drugs in this space. Again, this is, I don't expect you to kind of note this particular figure because it's quite busy, just to say that there's 2 trials, and this other trial, which this kind of complex design measuring time to no pustules at all, is currently under investigations, and we should know about this drug very soon. So very promising for this rare but potentially quite severe condition. Some of you may already know about this drug called Bemzilex, or bimekizumab. I think this is one of the newest biologics we've got available to us in clinic, and really here we're looking now at 90% improvement in the PASI, which is the graph on the left, and then IgA, which is very similar to no psoriasis or very mild psoriasis, and you can see that it really does quite well compared to a drug that we use very often, which is adalimumab. So you've got 86% getting 90% clearance or more, compared to around 50% for adalimumab. One thing to note is that column for oral candidiasis, I think it's quite small, but you can see that there are no cases for adalimumab and a few cases for bimekizumab. So that's a quirk of the medication that you do need to be aware of before you start the medication. And a similar comparison trial comparing bimekizumab to secukinumab or Cosentyx, you can see that this is now measuring complete clearance, no psoriasis at all. Over 60% of patients on bimekizumab had a complete clearance, but about 20% did have oral candidiasis, which is very treatable, but is something to be aware of. And I'd recommend, if you are very interested in reading about research, or you're struggling to get to sleep, you can actually go to this website. I shouldn't really say this because this is a really good website, but this is basically a load of work that has been done by the Cochrane team. This is a team put together by Cochrane, which is one of the leading evidence-based medicine organizations, and really putting all the data we know from trials together, comparing the different injections into something called a network meta-analysis, which is basically putting all of these drugs and data together. And one of these graphs I find is the most intuitive to see is to look at both the safety, which is measured by severe adverse events on one scale, so on the y-axis, on the kind of vertical axis, and PASI 90, which is 90% clearance in psoriasis, which is on the horizontal axis. And basically, the further you are on to the top right corner, the better it is for both safety and also treatment effect. So you can see this is all kind of in letters, but BIME is bimekizumab. It kind of ranks very similarly to risankizumab, another drug we are now often using for psoriasis. So these are clustered together. So it shows that it is one of the most effective biologics we have. And just keep an eye out for this website, because this is something called a living network meta-analysis. And that means that there's a team of researchers doing research every couple of months just to try and get that data together. So any new trials will then feed into this website. So hopefully every time you go onto this website, it's going to be the most updated one. So you know that you're looking at the newest data, really. So this is my very quick start to new treatments. I can't pronounce half of these drugs, but basically this is just to show that there are still new developments and new pipeline drugs coming out under investigation. Okay, so I'm back onto safer ground with BADBIR, and this is an old slide now. I'm sure you've heard about BADBIR before, but it's really important just to emphasize again how important this research project is and how crucial it is to have both clinicians but also patients, researchers, and everybody coming together to provide us with the data to help really improve the care of psoriasis. I can't remember the updated numbers, but it is more than this. So we have over 20,000 registrations, and these numbers speak for themselves. It's a really valuable database. Hopefully it will continue to provide us with a lot of useful information to help clinical care, especially with regards to safety of medicines going forwards. So I'd like to thank the Psoriasis Association for supporting Bin's PhD. He's one of our PhD students, and he's really working on the topic of biosimilars. And this is his face here. Hopefully you'll get to meet him in another annual conference later down the line. So he performed a couple of pieces of work. His first piece of work was a drug utilization study. And it's just to kind of circle back onto the topic of biosimilars. These are similar, but not exactly the same drugs that are out there. So a lot of you may be very familiar with these pens. So this is all the same drug called adalimumab, but it's produced by different companies with different cell lines. And this means that there are subtle differences that are not to do with how these drugs work in terms of binding, but other more complex structural things that may be slightly different. And the analogy I use is a little bit like having carrot cakes from different companies. I think the left is from Marks and Spencer's, and then the right is from Tesco. They're both carrot cakes, essentially. They both taste like carrot cakes, and they both have roughly the same ingredients, but they are slightly different in terms of they're coming from different brands, from different factories, and they will have differences that do not make it not a carrot cake, but often you will prefer one over the other. And really, the interest from BIN and our study is to try and understand what those differences may lead to in terms of what happens to people who receive these medications. So he started off looking at the literature, as you do, and trying to look at all the trials that are out there. Again, very busy slide. One thing to note with biosimilars is that they can be licensed and approved based on trials on other conditions. So this means that you may be receiving a drug which was, it's still adalimumab. Adalimumab itself has been tested before for psoriasis. We know it works, but that particular brand has only perhaps been tested in patients with rheumatoid arthritis. And so we really wanted to just look at the trials investigating psoriasis. And don't ask me what those names are for the investigated biosimilars. I can't really remember, but essentially this is trying to put that data together. And you can see that there are quite a few trials out there with quite a few number of participants, and they're pretty good. So what we look at for how robustness, how trustworthy are these data, is to look at that column for risk of bias. And we used a particular tool that was recommended by Cochrane. And you want things to be low generally. So they are low to moderate. There are some things that are not very clear, but most of them are good pieces of data. And you don't have to really kind of read into the detail of this, but when we put things together, we like to put them in something called forest plots. So it's very small, but these lines, if they cross the midline, it's telling you there's no difference between the comparator. So here we're comparing biosimilars to the original product, which is Humira for adalimumab, let's say. And you can see that all of those little horizontal lines cross the main vertical line, really showing not much difference. But the wider the line, the more uncertain we are that there is no difference. So you can see that for some of those little lines, for example, for adverse events right down there, those lines are probably a bit longer than what we want. And so it means that there is still a little bit of uncertainty, especially when we're looking at switching, which is the main thing that is difficult to look at with this type of data. But of course, we know that sometimes things don't pan out like they do in the very restricted trials. And we wanted to look at what's happening out there in the clinic. And these are cohort studies where we don't do anything except observe, a little bit like BADBIR, just observing what's happening. And we want to include all patients, not just patients eligible for trials, but everybody that are exposed to these medications. And here we found only 3 studies looking at what we call real-world evidence. And unfortunately, when we look at how trustworthy these are, the risk of bias is now a lot higher. So we have serious risk of bias for 2 and moderate for 1, which is really indicating that more work needs to be done. And it's hard to have a concrete takeaway or summary from this type of data. So following from looking at the evidence that's out there, BIN then started to look at the data within BADBIR and really tried to understand just the drug utilization, what is happening out there. Now, it is important to note that BADBIR, although it's very comprehensive, it isn't a 100% record of everybody on these drugs. So there may be some discrepancies with what is happening in out there. But I think we can take some takeaways from the general data. One thing to note is that there's a lot more switching or take-up of biosimilars for adalimumab compared with the older biologics, etanercept and infliximab. These three, all of these are from the same class of biologics called tumor necrosis alpha inhibitors. But for adalimumab, which is a lot more used, a lot more common, we have a lot more use of these biosimilars. It's important to note also there's differences in the regional guidelines and regional decisions in terms of whether to switch to a biosimilar or which one to switch to. So if you look at that graph there for adalimumab, you can see quite a bit of difference between the regions. So in Scotland, there's a lot more take-up of biosimilars compared to, for example, London, which you've got 12.5 here, and there's some variety in the different kind of areas, most probably reflecting the different decisions made locally on whether to switch these patients onto biosimilars and also the deals that were made there. So just to super quickly kind of run through these switching data, that graph to the left really looks at how much switching is happening, a little bit like the graph we looked at before, but just in another way. So the more steeper the curve, the more the pickup and switching from the originator to the biosimilar there is. And you can see there's a lot steeper curve for adalimumab compared to etanercept and infliximab. He then produced one of these regression models, throwing all this data together to try and find out and understand who are the people who are more likely to get switched from originator drug to a biosimilar. And he found that patients who were male were more likely, patients with diabetes and with more higher disease severity were less likely, and then also the different drugs had a different difference in the pickup. So this was not unexpected, but really interesting to see this data come together. And he's going to then move on to try and look at this in a bit more detail. He then started to kind of do these plots to try and understand the pathways and just see how many patients were kind of going through these different pathways. And you can see quite a few, for example, for adalimumab. I'm just going to concentrate on this one now. You can see that quite a few then switched from the originator to biosimilar, and then very, very minor proportion of those patients switched back to another biosimilar. Some patients stopped their medication and most likely switched to another drug. And that's kind of quite a common pattern across the different treatments. And when we delved into the different types of adalimumabs that we have in BADBIR, you can see the majority of data we have is for one drug called Amjevita. The second is another drug called Amrowdy. And you can see that very minor proportions of patients switch from one biosimilar to another one. A lot of these patients stopped and switched on to another drug. Again, very interesting data that he'll start to delve into a bit more to try and understand now the safety and effect of these medications. And hopefully he'll come to talk about his work in the near future. So moving on to something else that we can look at with BADBIR, which is treatment effect. One thing that we don't have a lot of data on for both trials and real world evidence, what's out there in the clinic, is using the more traditional older drugs that you may have heard of, the drugs such as methotrexate, cyclosporin, acitretin, and even fumaric acid esters such as Fumoderm or Skilarence. And here, one of our research associates, Oris Alibas, started to look at our data on the effectiveness of these drugs. And it's much more difficult to look at because we use these drugs in a variety of different ways. And each physician obviously has slightly different preferences, but it's really interesting to try and put this data together. Here, what she's done is to look at a slightly different outcome of PASI less than or equal to 2. That really means very mild or no psoriasis at all. Analogous to 90% clearance, and then also less than or equal to 4 roughly 75% clearance. And you can see these differences there, probably not surprising to clinicians who are used to using these drugs. You can see cyclosporin methotrexate probably a bit better at treating psoriasis, acitretin and fumaric acid esters slightly lower, but still effective in quite a few different patients as well. She then started really delving into different factors and trying to see whether there were predictors of response, whether or not particular things to do with the patient history or background could be leading to different types of responses on the different drugs. And she found a couple of these differences that we've highlighted here. So again, we've got these kind of forest plots, but just to summarize, that she found that for people who are on acitretin, those who had a couple of different medications already tended to do a little bit worse. For people starting cyclosporin, people who had a few comorbid conditions and a bit of a lower alcohol intake seem to do a bit more poorly, and perhaps this is to do with patient selection and the clarity of our data. I think it's very difficult to get very accurate alcohol intake data on BADBIR. And then for methotrexate, male patients seem to do less well. Again, it perhaps is a reflection on the patient selection of female patients who are much less likely to go on methotrexate if they were of childbearing age and perhaps chosen because they had less severe disease or more stable disease. So it's difficult to completely understand what's going on there, but it's the first step in trying to understand what's happening with these more traditional treatments. So I'm going to have show lots of these slides with lines that are going down. And basically for all of these slides, the steeper the line, the worse the drug is at whatever we're measuring. So the one on the left, we're measuring treatment effect, and this is measuring discontinuation. So in essence, the steeper the line, the more people are discontinuing because their drug isn't working. The one on the right, the steeper the line, the more patients are stopping their medication because they developed an adverse event. Or more than one adverse event. So the steeper the line, the worse it is. So you can see, not surprisingly, reflecting the PASI results, the steepest line on the left is acitretin. So it tends to work less well. But still, about 50% of people are getting good benefit past 1 year. For a safety, it's a bit more surprising, actually. We found that methotrexate, although not too different with acitretin, does seem to be the safest drug. Perhaps not surprising, the cyclosporin and fumaric acid esters does tend to lead to a few more side effects leading to stopping the drug. But just to reiterate also that even for the steepest curve, about more than 60% of patients who are on these drugs are continuing these drugs and not having any side effects from the medication. So just to very, very briefly talk about comparing these old drugs to new drugs, Oras then proceeded to try and compare methotrexate, kind of a staple old drug that we use, to adalimumab, which is a staple newer drug that we use, the biologic that we use. And it's not really been done that much. Just circling back to the Cochrane review, we had an effect of about 3.7. So we were expecting adalimumab to be about 4 times better than methotrexate. And we found roughly that it was, roughly speaking, that was the case. So the risk ratio, when we were comparing different types of comparisons, we are at least confident that in the real world practice, adalimumab is at least twice as good as methotrexate. And we're not entirely sure whether or not it's twice or 4 times, but it's kind of in between that kind of area. So again, confirming that these drugs do work very well in the clinic as well. So I'm going to very briefly crack on because I don't have too much time. Here, the same type of chart. So the steeper it is, the worse the drug is. And here we're looking at survival overall. So more people discontinue methotrexate compared to adalimumab, and that's across both treatment effect and also safety. So I guess just to move on to the newer drugs, one of the recent studies that we did was to compare the different newer drugs in terms of how long patients persisted on these drugs. And you'll notice that across all of the biologics now, people tend to do better on these compared to the more traditional drugs. So here, what we were trying to understand is what about the treatment history of the patient is affecting treatment persistence. And we've split it by patients who've had no drugs, no biologics before, one biologic before, or two or more, and seeing what happened to the treatment outcomes. And here you can see these are all patients who've never had biologic treatments before. We tend to get pretty good persistence. All the drugs tend to do pretty well, but we've got definitely ixekizumab and guselkumab, two different modes of actions. I'm not going to go too much into the different drugs right now because I'm running a little bit out of time, but essentially these are the newer treatments targeting interleukin 23 for guselkumab and interleukin 17 for ixekizumab, more targeted types of treatments. And these two tend to do better than the older ustekinumab and secukinumab, and then adalimumab we've talked about already tends to do less well compared to those. But when we move to different types of patient history, now these are patients who've had one biologic before. Everybody does slightly worse, and that's because they probably have more severe disease, but you tend to get a difference in the comparison. So now guselkumab, the interleukin 23, does tend to clearly be a little bit better. And then when you move across the lines, it tends to be better than, for example, interleukin 17, which you do get that marked drop off. So those green lines, that's ixekizumab and secukinumab, both of them are much more steep than what they were before. So really telling us that there's something about patient selection, and if you failed a couple of drugs, perhaps those ones that are more steep might not be the ones to go for. It might be better to think about the ones that are less steep, of course, taking into consideration the different other factors that may be coming into play about choosing a biologic. Very quickly on safety, just want to introduce Ali Al-Janabi's work because it's really interesting. We noticed in clinic that some patients were somehow getting flares of what looked more like eczema rather than psoriasis after starting these biologic treatments. And he started to look at what's happening in BADBIR with this quite rare side effect. And one thing he noticed was people who had conditions that were more associated with eczema. These are asthma, hay fever. Those patients tended to be the patients who might get this eczema breakout. It does tend to be more common in female patients as well, but the age is roughly the same. And when he started to look at what drugs were more associated with having those breakouts, he found that ustekinumab compared to the other drugs tends to be a bit more associated. Now, we've talked about the length of the horizontal lines before, and you can see how long these are. So it's telling us we're really not very sure about this outcome because the number of patients is quite low. But it's really interesting finding that we need more research into really, and that really shows the strength of something like BADBIR to try and interrogate something that's quite rare that we've noticed in clinic. We can try and understand a little bit more about this side effect. So I'm going to end my talk with introducing another PhD student that's very generously supported by the Psoriasis Association, that's Heber, and he's going to start looking at serious infection risk especially with the newer biologics that we know less about. So these are the 17 and 23 inhibitors, and he's going to do something very similar to Cochrane team to put that data all together so that we have a good idea of how all of the drugs compare to each other, and then he's going to look at BADBIR and try and understand the relative risk of getting infections. And where he's up to is he's registered the protocol on a database out there. So he's kind of placed his bets now. This is what we're going to do, and he's starting to work on the literature search and also trying to get his data set together. And really, this slide is just showing you the steps that he will take. Essentially, he's going to look at many different databases according to his protocol, include those trials, especially the trials that are already included in that particular Cochrane review. He's going to screen and really put that data together, pull all of the data together and put it in a network to compare to each other so that we really have a good idea of what the infection risk is of all the treatments we have for psoriasis compared to each other. Hopefully that's been clear. It's quite a lot of different work, but it's really, I would like to just again acknowledge that all the inputs of all the patients, all the teams across the country putting data into BADBIR. This is all the principal investigators, all the research nurses, recruiting doctors. We have a big team in Manchester looking after the database, taking queries, reporting adverse events to the regulatory authorities. I think it's really important that we do this to make sure that the medicines, especially the newer ones, are safe for patients. And again, would like to thank the study group as well for leading this project, and also just to thank again the Psoriasis Association for generously supporting BIN and Heber's work on BADBIR. Thank you very much.